Good afternoon, folks, or good morning if you're on the West Coast. This is Steve Conley. I'm the Executive Director of the American School Health Association, and we're really delighted to have you with us today. We've got a stellar faculty. We're blessed with some folks who really know their stuff and are up to date, and we'll be able to give you the latest information, and you'll be able to ask questions from the experts today during the next hour of this workshop. When we first began organizing this webinar, we expected the attendees to probably number less than 100. We were hoping to get about 75 people. And as we begin the session, I see we're over 300. And we actually today had 900 professionals register for the session. We're also aware, and we've heard from a few folks, that they're in rooms across schools across the country where they may have one person who registered, but perhaps there are 10 or 12 or maybe even more from the medical side of the school who are attending to catch up on asthma. And we're really pleased to have this many in attendance. It's told us that we definitely are taping the recording. It will be used on the American School Health Association webpage in about a week. And the faculty has agreed today to stay, most of them at least I think, after the hour. So if you have questions after 3:30 Eastern Time, then you will be able to ask those questions. And hopefully you're seeing on the screen how you actually begin and how you enter a question, and the faculty will be able to provide you with an oral answer to the question. Please be patient with us. This is the first time we've used this sort of fancy communication equipment, and I definitely am not that dexterous with this type of dashboard. But again, we're excited. Let us know by questions, or you can call us, and if something else is going wrong. I hope the sound level is okay. Well, during the next hour, we're going to be asking for information from you as well as providing information from our experts. And please reply to our polls, because if you do that in a timely manner, it's going to help them tailor their presentations. And in about a week, you'll receive an email. We would really appreciate your evaluation of how well we do this hour. And in addition to this webinar on asthma, our staff, primarily Kate Eig-Hurwitz, is developing a special portal for asthma information and resources, which will also be available from the ASHA webpage. Please visit us often there and help us to create the best possible asthma tools for critiquing the portal and its contents. The American School Health Association is a multidisciplinary professional membership group of about 1,800 individuals now. And our mission, as you can see, is to build the capacity of members to plan, develop, coordinate, implement, evaluate, and advocate for effective school health strategies that contribute to optimal health, academic outcomes for all children and youth. We have a very well-received and powerful journal of school health, which comes out 12 times a year and is one of the leading sources for information on the latest related to school health, as well as some incredible archives. We do an annual conference. If you're not a member, I would suggest you consider joining us. If you come to the conference, you get, of course, reduced rates. It's reduced rates for the journal as well. And you have a huge networking group of professionals who work in school health. This October, we have a conference in Louisville, Kentucky, which is drivable for most folks in the Southeast. And we really hope we can see a number of you at the conference called Limited Possibilities in School Health. Asthma has done a great deal of work in the area of asthma. And we're working with Ben Francisco, Lani Wheeler, and Deb Cook today to create asthma-friendly schools across the country by increasing the number of school-based personnel who can assist students with asthma to manage their disease and to make them able to identify quickly and to respond appropriately to asthma episodes in schools. And our goals are, and we hope that at the end of this hour, participants will be able to name the 6 GIP messages, describe the school nurse role to promote asthma control, and understand how advances in school-based asthma management can help in applying the GIP messages in schools. And we hope you can describe techniques to overcome barriers to school-based asthma management. Our presenters today are Lani Wheeler, whom I mentioned, who's down in Florida today, Dr. Ben Francisco and Deb Cook, who are in the state of Missouri. And we're very pleased to have these folks with us. To begin with our presentation today, we do want to find a little more about you, and it looks like the first thing I've got to do is figure out where to find the poll question, if you'll bear with me. Let us know, if you would, your nursing credentials, and we'll leave this open for a while to allow folks to respond, and ask as many of you who are near a keyboard to please give us an idea whether you're a nurse practitioner, registered nurse, or the other categories. And hopefully you can see the results of this first poll that we have overwhelmingly registered nurses as our attendees today. Can you tell us in what school setting you work? And hopefully I can get to the third question a little more quickly. If you're near a keyboard, please let us know. If you're in elementary, middle, high school. It appears the majority of our folks are in the elementary school level, and we'll share this information in about 5 seconds. So hopefully, Lani, can you see the poll results?
Yes.
Very good. Let's take one more before we move to the faculty and the folks that really know their stuff. Now we're trying to identify how many students that you have per nurse. Thank you, folks, for being so quickly with this. So far, with 2/3 of you in, we're running at about 60%, have 750 students or less per FTE of an RN. And I'll close this again in a couple of seconds. So we're at 60% with 750 or less. At this point, I'm pleased to open up with our first stellar asthma expert, and this is Dr. Lani Wheeler. Lani is a public health pediatrician and a consultant in school health, especially school asthma programs. She chairs the National Asthma Education and Prevention Program's School Education Subcommittee, and she represents the American School Health Association. Lani worked in public health in Maryland for 22 years, where she developed and directed child health and school health programs. She worked as a medical officer with the Centers for Disease Control and Prevention and the U.S. Environmental Protection Agency. And there she developed evidence-based community programs and supported materials. Lani is now semi-retired, and she's living in Southwest Florida. At this point, Lani, I'm going to offer you the screen. Whoops. Lani, are you still with us? Because I can't find you on the listing.
I'm here.
For some reason, you're not showing up. If Ben Francisco would not mind, I will switch to him while I try to fix this technical problem.
That'll be fine, Stephen.
And I'll let you know that Dr. Francisco is a research assistant professor of pulmonary medicine and allergy in the Department of Child Health in the School of Medicine at the University of Missouri in Columbia. He's director of Asthma Ready Communities, a principal investigator for several asthma improvement initiatives. He is a practicing pediatric nurse practitioner at the Missouri University Women's and Children's Hospital, University Physicians, the Pediatric Specialty Clinics in Columbia. Dr. Francisco is the principal author of Impact Asthma Kids. It's an evidence-based multimedia educational program for school-age children. His research activities include analysis of administrative claims data to target and evaluate asthma interventions. He has worked in workforce development to improve asthma care in schools, clinics, hospitals, and community agencies. He's done assessment of airflow obstruction in childhood asthma and into the improvement of children's inhalation techniques. So, Ben, I will turn this operation to you at this point.
All right. Thank you, Stephen.
Oh, thank you.
All right. Do we have the first slide up, I hope, out there?
Yes. You're a little dim, Ben.
All right. I do want to tell you that I have intellectual property rights and a financial interest in the multimedia program Impact Asthma Kids, which is owned by the curators of the University of Missouri. And in this talk, I won't be talking about any experimental or off-label use of medications or devices. I think the wonderful thing we can say about asthma is there are so many opportunities to make a difference in the school setting. And we can do that by focusing on some real basics. And what we seem to be missing in most settings, school, clinic, and hospital, is that really asthma is a disease that involves long-standing airway inflammation that periodically results in airflow obstruction, and that causes symptoms. Another critical point we're missing is that there's a great class of medications that are highly effective. That's the inhaled corticosteroids, or ICS. And so when our students are on that medication, they have dramatic improvements in their asthma outcomes. Having the medicine and getting it into your lungs are two different things. So we know that about 95% of both children and adults who have inhalers at home or at school really have poor technique and are only getting a small amount of their medicine into their lungs. So this is certainly something we can improve. I think we need to understand that asthma makes it hard to breathe out the old air from our lungs, and that's measurable. So when we measure airflow in asthma, that's like assessing temperature for an ill student, or checking blood sugar for a diabetic student, or blood pressure for a hypertensive student. So that physical measurement is very important in recognizing and identifying the presence of the disease. Airflow obstruction can be triggered by all sorts of things, but by far the most common problem is the simple cold. There's 200 different viruses out there that can cause cold symptoms, and each of these viruses has some capacity to trigger inflammation in the airway of someone with asthma. Another very important thing that we have a role in protecting our students from are volatile organic compounds, or VOCs. And we know that VOC exposure at school and at home often precipitates sudden and rather severe airflow obstruction. Smoke, pollen, mold, animal dander, and other airborne things also have very important roles in triggering asthma. Asthma is also associated with other conditions or comorbidities, and the most important ones are being depressed, being overweight, being inactive, having gastroesophageal reflux disease, and having nasal obstruction, as you would see with allergic rhinitis or sinus infections. So good asthma care means that we're able to control the asthma and that there would be no impairment and minimal risk in having the disease. And it really requires regular visits to the medical home where we can assess asthma control and adjust the plan of care, and most importantly, promote self-care, and that's providing education to parents and students so that they understand asthma. Today, most people do not have an adequate number of follow-up visits with their primary care provider, so that's a key message school nurses can reinforce. We're very excited in Missouri about the demonstrated ability of school nurses to assess airflow using electronic meters, and their ability to also ask key questions that would detect impairment, to coach students so that inhalation technique gets better, and to increase the students' adherence to inhaled corticosteroids, and generally to contribute to the improvement of students' self-care. These efforts are of huge value to the family, to the student, and to clinicians. We are using digital meters in the state of Missouri to assess airflow. And, historically we've looked at peak flow, but it turns out peak flow is not the best measurement. We can easily obtain the forced expiratory volume in 1 second. That's what FEV1 stands for. That's just the amount of air that you can blow out of your lungs in 1 second. So school nurses can document the personal best FEV1 of students and then compare that number to both predicted values, which will identify that some students are walking around every day with significant airflow obstruction. That baseline or normal FEV1 for a student also helps you know when students are having significant airflow obstruction. So if they report symptoms, the measurement of FEV1 and identifying a 12% or greater drop clearly indicates that the asthma is flared and triggered by something. And then you want to provide albuterol and 20 minutes later reassess. If you provide that report to the family and to the clinician, this is great evidence for the adjustment of therapy. There's a number of brands of electronic meters on the market. This is one that we use extensively in Missouri. It's called the Asthma One. Very easy to use. It does require a forced expiratory maneuver where a student fills their lungs and blows out hard and fast. This device also gets you a peak flow measurement, so we're not discarding peak flow. Peak flow is often used at home by students, although not all students with asthma need a peak flow meter at home. It's inexpensive, so one device serves the whole school. You do need a disposable mouthpiece, and that runs about 35 cents per student. We do store these in special ways so they can be reused for a student for the entire year. So we think that you can advance asthma care when you use digital meters to both assess airflow and to also aid efforts in coaching for inhalation. And this is not obvious, but it is easily understood. The expert guidelines for managing asthma tell us that meter dose inhaler medications should be inhaled at a rate of about 30 liters per minute. So after emptying the lungs of old air, if a student slowly fills the lungs at this ideal speed, it actually takes 2 seconds to get a liter of air. So that means if you know the student's FEV1, you can multiply that times 2, and that's the ideal time it should take a student to fill their lungs. So we've learned that by telling students what their target time is, you're really empowering them to care for themselves in this important way, which is regulating the flow of air and medication into their lungs. And this means that a student who perhaps was getting only a fraction of their medicine in their lungs is now receiving a much higher dose and good benefit. That's important to you at school when they're in trouble breathing and you're offering albuterol, but it's even more important at home when they're taking their ICS medicine that's going to stop the inflammation and extinguish most of their asthma symptoms. So we've developed instructional materials to help students understand the importance of regulating the flow of air and medication into your lungs. If you go too slowly, the medicine falls out, rains out into the mouth. If you go too fast, it travels in a straight line and runs into each curvature of the airway, the most important one being the back of the throat, but there's 23 other curves or branches of the airways as you go down into the lungs. If you go at the right speed, that is, you fill your lungs in your target time, the medicine can follow the curved pathway and you get great lung deposition and really good results. I think sometimes school nurses struggle to know how to communicate the worries, the concerns they have about their students. And we found in Missouri that there's a great tool that's been validated. It's from the American Academy of Pediatrics called the Children's Health Survey for Asthma. And it's a 12-minute survey. We've just taken out of that survey 6 critical questions that look at how well a student's functioning. And so we have encouraged school nurses to ask these questions, especially at points of concern about a student, but even on a new student that you're initially assessing. And these questions get at the issue of, are you able to do normal things, or are you limited in some way by breathing problems or persistent cough? So the questions are, in the past 2 weeks, did asthma keep you from doing these things? We start with playing at friends, neighbors, relatives. Sometimes that's because of a parent's fear that they're unsafe out of the parent's sight. The next question has to do with running fast or playing hard, things that use a lot of energy. Many students with asthma have trouble when they really push themselves. Some students have problems just shooting hoops, dancing, walking upstairs, or things that really require a moderate level of activity and increased breathing or minute ventilation. And the students we, of course, worry a great deal about are those who have difficulty breathing, even just walking and taking being involved in light activity. Asthma is worse at night between 2 and 4 a.m., so students who wake up and need treatments at night certainly are not well controlled and are impaired, and their school performance is likely to suffer from the loss of sleep. And the last question is really an environmental question. We're encouraging families to protect their children from smoke exposure, and we want to hear from students whether that's happening or whether there's a problem. So in conclusion, there's some things that we can all do at school to help students, and we think of these really as literacy issues. If you have asthma, you should know some basic things. Number one, asthma makes it hard for you to breathe sometimes, and you really have to measure airflow to know how much trouble the asthma is causing, and really FEV1 is the better measure compared to peak flow. Most people cannot feel the airflow obstruction caused by asthma until it's rather severe. Second key literacy point is that inhaled corticosteroids, or ICS, are the most effective medicines, but you have to take them for 2 to 3 months to heal the airways. So you have to be patient. You have to commit to that course to see the full benefit. When you breathe a medication into your lungs, that's a very special skill. You need coaches to help you, and if you know your target time, you're more likely to do that well. And finally, by recognizing and avoiding asthma triggers, you can keep asthma under control at lower medication levels, meaning that triggers often drive the asthma, and removing triggers from the environment will reduce the level of asthma and the amount of medications that are needed. So we've developed a program called Teaming Up for Asthma Control, complete with online training. In 2003, a survey of Missouri school nurses said we need 3 things. We need distance education. I need to be able to learn about asthma from my school instead of traveling somewhere and spending the money and time to attend a meeting. We need equipment for our students because many of them come to school with no valve holding chambers, no peak flow meters, and we need age-appropriate instructional materials. So that's why we labored to develop in Missouri, and we're in the process of evaluating that and hope to be able to tell you more about it. In a pilot study, children increased their FEV1 by 16% over the 5 weeks they participated in the literacy program, and this represents a huge increase in airflow. So we're hopeful that this will offer help for a lot of students. Thank you very much. I'll turn it back to you, Stephen.
Ben, thank you. Thank you immensely. We have actually managed to fix the technical problem, and I've already introduced Dr. Wheeler, and we're very lucky now to have her back on the line. And we'll move to Dr. Lani Wheeler.
Thank you, Steve.
It's a little bit low, Lani, if you can come up a little bit.
Sure thing.
There you go.
I want to spend a couple of minutes now explaining how each of you fit into the big picture of the National Asthma Control Initiative. NAEPP is a program of the National Asthma and Education Prevention Program, that's NAEPP, which is coordinated by the National Heart, Lung, and Blood Institute of the NIH. NAEPP is a multi-component, mobilizing, and action-oriented initiative to engage diverse stakeholders who are concerned about or involved in improving asthma control. Its ultimate aim is to bring the asthma care that patients receive in line with the evidence-based recommendations. You can find more out about NAEPP at the NAEPP website. The American School Health Association was awarded funding for a strategic partnership with NAEPP in order to do things like this webinar today. We've done face-to-face trainings, and also to develop the asthma porthole that Stephen mentioned earlier. We're going to be grouping all the materials that are focusing on school-based asthma education, especially for school nurses and other school personnel, on one website, so you'll be able to find all that training material in one spot. Here's a quick review on asthma in school-aged youth. About 10% or more than 5 million school-aged children have asthma. On average, students with asthma miss about 2 to 3 days more per year than students without asthma, although some students with severe or out-of-controlled asthma miss much more than that. Asthma is serious and can cause students to go to the emergency room, urgent care office, be hospitalized, or in the worst case, even die, even at school. On average, a typical classroom of 30 students is likely to have 3 with asthma. Student learning can be impacted by fatigue, absenteeism, or symptoms that interrupt students' attentiveness. An asthma episode can be distracting and upsetting to other students and staff. Students with asthma sometimes experience lower self-esteem, and their academic success can be affected by missed class time and absenteeism. Some students with asthma feel anxious about participating in physical education or other activities because they're afraid they will experience an asthma episode. There is no cure for asthma, but it can be controlled. Most young people with asthma should be able to live healthy, active lives with minimal symptoms. So let's talk about how you can help students control their asthma at school. You can follow an individualized written asthma action plan. Each student's plan should come from his asthma care clinician. If a student in a classroom is sensitive to specific allergens or irritants, you can help reduce or eliminate those allergens or irritants. You can teach and encourage students to use their asthma medications as prescribed. You've heard a little bit about that from Ben already, and Deb will be talking more on that later in our webinar. We're interested to know how many of you have heard about EPR3, and we're going to give a try at another polling question. Steve, can you put that EPR3 question up?
Let's see if I can get to that. My apologies, Lani.
Okay. Well, you can just think in your heads then. We've done surveys before, and not as many of you have heard about it in general as we'd like. So I'll give you a little update on EPR3. EPR3 was actually written in 2007, and it was developed by an expert panel commissioned by NAEPP. Since 2007, many of us have been updating our asthma guidance documents to incorporate EPR3, so we're going to take a quick look at some of the key points. The goals of asthma therapy didn't change, but there is some new guidance on how to achieve those goals. The goals include reducing impairment, meaning preventing symptoms, reducing the need for albuterol, maintaining optimal pulmonary function, and of course maintaining regular activity and quality of life. It also means reducing future risk of exacerbations, ED visits, hospitalizations, preventing progressive loss of lung function, and providing optimal therapy with no or only minimal adverse effects from medications. The expert panel identified 4 essential components of asthma care: assessment and monitoring, patient education, control of factors contributing to asthma severity, and pharmacologic treatment. A few of the highlights include pointing out that treatment recommendations need to be based on severity, the level of control, and responsiveness. EPR3 also pointed out that patient self-management education needed to occur at multiple points of care, not only the physician's office, the ED, but also school and other child care settings. It also emphasized that in order to reduce exposure to inhaled indoor allergens to control asthma, a multifaceted approach is necessary, sometimes requiring home environmental assessments. The bottom line for school-based asthma programs is focus on asthma control. Students with asthma can and should have their asthma under control and miss no more school than students without asthma. School nurses can target services for students whose asthma is not under control. So what is control? Well, technically, it's classified as well-controlled, not well-controlled, or very poorly controlled, and requires a detailed health history and spirometry measurement. But here's the simplified assessment that we can keep in our minds, and that is that asthma is not well controlled for ages 5 to 11, so think elementary school students, if they have asthma symptoms or use a quick relief inhaler for symptoms more than once in a day or more than 2 days a week, or if they have nighttime awakenings due to asthma more than once a month, or any interference with normal activities. Now, these guidelines are much stricter than had been recommended prior to 2007. The guidelines are slightly different for older students, and that is asthma is not well controlled for ages 12 and up if they have asthma symptoms or use a quick relief inhaler for symptoms more than 2 days a week, have nighttime awakenings due to asthma more than twice a month, or any interference with normal activity. The GIP report came next, and this is the guidelines implementation panel that identifies recommendations and strategies for actually implementing the clinical guidance of EPR3. It contains 6 priority messages that we're going to emphasize. The 6 messages include inhaled corticosteroids, asthma action plans, asthma severity and control, follow-up visits, as well as allergen and irritant exposure control. I'll go through each one. You can also download a handout that you should have been advised about in the notice for this webinar, where the American School Health Association has developed specific messages for schools in relation to each of these GIP messages, and I'll be focusing on them. The first message, of course, is inhaled corticosteroids. GIP tells us that control medications should be taken on a long-term basis to achieve and maintain control of persistent asthma. This means that parents of school-age children with asthma should be aware and educate their children that inhaled corticosteroids are, first, the preferred medication for persistent asthma, that it's safe for long-term use, that it's proven to reduce the risk of fatal asthma, that it's only effective if carefully inhaled, usually twice daily, and that it should only be discontinued under the advice of a qualified healthcare provider who can carefully monitor lung function in the following months. Then the next recommendation is that all patients with asthma have a written asthma action plan that includes instructions for daily treatment, meaning medications as well as environmental controls, and how to recognize and handle worsening asthma. The message for us isn't new, and that is to obtain and use an asthma action plan for each student with asthma. The next GIP message focuses on severity. Once a diagnosis of asthma is made, clinicians should classify asthma severity based on measures of current impairment and future risk in order to determine the type and level of initial therapy. The message for schools is, of course, to refer students for an initial assessment of severity if one hasn't already been made. Next is getting back to control. Every patient with asthma should be taught to recognize symptom patterns and/or use diminished airflow, that's FEV1 measures, that indicate inadequate asthma control and the need for additional therapy. Control should be routinely monitored to assess whether impairment and risks are reduced. For school nurses, this means monitoring and reporting the frequency of the need for quick-relief medications, the impairment related to these breathing problems, missed school days, and records of diminished airflow measures. Remember to communicate regularly with parents and asthma clinicians, especially when asthma is not under good control. The next GET message is that patients with asthma should be scheduled for planned follow-up visits at periodic intervals in order to assess their asthma control and modify treatment if needed. This means students with well-controlled asthma should see their clinician at least twice a year, and students with poorly controlled asthma should see their clinician every 2 to 6 weeks. The school nurse can encourage regular follow-up visits and assist those students who don't have a medical home to enroll through child health insurance programs. The last GET message reviews patients' exposure to allergens, particularly indoor inhalants such as tobacco smoke and other irritants, and points out that it's necessary to provide a multifaceted, comprehensive strategy to reduce exposure to these allergens and irritants. Schools can develop and implement an indoor air quality management plan to reduce triggers at school, and you can also provide asthma self-management education to help students with asthma to reduce their exposure to allergens and irritants at school. Managing asthma, of course, can't happen at school alone, but together we really can make a difference. You can take steps to help students keep their asthma under good control at school and can make sure that students get the care they need if they have an asthma episode at school. Deb's going to now be telling a little bit more about how she's done this in her schools.
Thank you very much, Dr. Wheeler.